Support for the BTPM NPR What's Next podcast comes from Health Foundation for Western and Central New York, partnering with the community to pursue racial and socioeconomic health equity. Learn more at hfwcny.org.
From Buffalo Toronto Public Media, this is What's Next, an hour dedicated to amplifying the voices of marginalized and underrepresented communities across Western New York and Southern Ontario.
We cannot erase, we cannot reform, we cannot make things better if we're uncomfortable having tough conversations,
Absolutely.
if we're uncomfortable talking about race.
What's Next carries forward our mission to engage in meaningful conversations about race, equity, and the shared concerns that deeply affect Buffalo's East Side and beyond.
Don't stop. Make those families part of your life. Their lives are part of yours. Don't stop.
Together, we dive into the real issues, striving for understanding, connection, and change.
In the suburban area, everywhere, we must work and teach our children.
Welcome back to another episode of What's Next. I'm your host, Ijaz Jasil. Today, we're taking a closer look at how one local organization is responding to growing behavioral health needs in Western New York. Jewish Family Services of Western New York recently received state funding to launch an adult critical time intervention team in partnership with ECMC. The program is designed to support people with serious mental illness and substance use challenges as they transition from hospital or emergency psychiatric care back into the community, with the goal of preventing gaps in care, homelessness, and rehospitalization. Joining me today are Dr. Molly Carr, CEO of Jewish Family Services of Western New York, and Dr. Katie Diebold, Vice President of Behavioral Health and Wellness Programs. Dr. Carr, Dr. Diebold, thank you both so much for joining me today.
Thank you. So excited to be here. I love this show.
I'm so happy. We're so happy to have you here. And I do want to just give a trigger warning to our listeners before we get started, as the topics of mental health and crisis intervention are expansive. There will be some discussion about things like substance abuse, self-harm, and suicide, but we do want you to be part of this informative and necessary conversation, as it may help you or someone you know. So to start, I'd like to get into the development of this new team. For people who have never heard of critical time intervention, which I'll be abbreviating as CTI, what exactly is this type of intervention and what problem is it meant to solve?
Yeah, so CTI is an evidence-based model that is designed to engage folks during a critical time, right? Critical time intervention. So the main problem that it's trying to solve is that we have folks that are highly vulnerable, that are repeat users of emergency rooms, psychiatric inpatient centers, and they have a lot of needs, right? So oftentimes they might be facing homelessness, they might have co-occurring substance use disorder, they might have food insecurity, and oftentimes because of those unmet needs, along with maybe mental health that isn't being treated or substance use that isn't being treated, they're ending up back in the psychiatric emergency room or the inpatient psychiatric department as well over and over again, right? So the idea of CTI is to engage them when they're coming out of inpatient or they're coming out of the psychiatric emergency room and really wrap services around them during that critical transition to help them to get connected to the things that they need in the community so that they're not going back to the hospital and having a quick readmission.
Okay, very good. And as we were kind of talking off air, the partnership between Jewish Family Services and ECMC has been pre-existing. Can you tell me about how you all have been working together and how this new endeavor is allowing you to explore new ways to partner?
Yeah, absolutely. So for the past couple of years, we have had an existing relationship with ECMC with our health home program and also our outpatient Office of Mental Health program as well. We've been on the floor. We've been working with them to identify clients that might benefit from our health home services. So naturally, when this opportunity became available, we were like, oh, this is perfect. We're already working with ECMC. We already have expertise in care coordination. We have expertise in behavioral health. Let's approach ECMC and ask if they'd be willing to work with us on this project. So now we'll be increasing our time that we spend there. We'll be continuing to be on the inpatient unit, identifying clients that will be eligible for the CTI program and working with them to identify those clients when they're already on the unit. Because what happens when that intervention doesn't happen right at the hospital, people can go out in the community and kind of get lost and maybe not get connected to services. So it's the opportunity to engage with them when they're right there at the hospital and enroll them in services.
Wonderful. So what role will ECMC play once a patient is discharged, and what role will JFS take over in the community?
Yeah, so ECMC, their main role is going to be identifying clients that could benefit from these services. So they'll be making the referrals. They'll also be engaging with our staff to let them know that they have a client that is on the floor who needs support. Then our staff will come onto the floor, meet with them, and enroll them in our program. Once they leave the hospital, that's when our services really start, right? So we're coordinating services with them, helping them get enrolled in behavioral health treatment, helping them get enrolled in substance use treatment, housing, nutrition, transportation. So really wrapping all of those critical supports around them. And then there might be times that these folks may have another reoccurrence of symptoms and they may end up back in ECMC. And that's where there's going to be ongoing case conferencing between our staff and the ECMC staff. So it's going to be an ongoing collaboration that we don't really see it being like a start or stop. It's really going to be an ongoing collaboration throughout the client's life cycle in our program and also throughout our entire relationship with ECMC through this program.
Okay. And understand that you all at Jewish Family Services are pivoting to focus more broadly on the needs of the local community. What are you seeing now that you weren't seeing maybe 5 or 10 years ago in terms of mental health in Buffalo and Western New York?
Yeah, well, I'll talk a little bit about the pivoting. So some people might know JFS as the agency that works with refugees. Other people might know us as the agency that works with Holocaust survivors. But we're really actually a very broad spectrum organization providing services across a really large swath of needs here in Western New York. But we did have some significant changes last year in 2025 when the executive orders came through that essentially brought a stop to refugee resettlement. And we found ourselves in a place where we had staff who had significant expertise in housing, in case management, in the delivery of career services. And we said, how can we capitalize on these expertise and broaden our reach in Western New York to provide these services to the general community who also need these kinds of supports. So, for example, in 2024, we helped 750 people get into housing, right?
Wow.
Many of them are refugees and immigrants. So we said, well, why don't we use that for the larger community that also needs these supportive services? And that way we don't have to, have the loss of this expertise in the organization. So we worked with funders to get in support to do housing here in Erie County and in Niagara County. So we're now able to provide a much needed support in housing aid and helping people get connected directly to housing. And we do it with a wraparound approach. So when somebody comes in, they may actually come in for care coordination in our health home program, but we identify housing as a critical need so we can connect them internally right to our housing program. Because we started to see these expansions in the delivery of services, we're also seeing some of the impact of all of these social determinants of health, how they're creating barriers to help individuals who are dealing with mental health crisis, to help them move forward in their own healing process. And I'm going to pass it over to Dr. Darbolt to talk a little bit more about how we're seeing that in the behavioral health side of our work.
Yeah, I think that more than ever, the social determinants of health are just impacting people. It is so stressful. We know that the cost of everything is going up. We know that there's a lack of affordable housing in our community across the state. I think the more that there's this economic stress, that's going to have an impact on people's mental health, right? If I can't afford to pay for my housing, I can't afford to provide food for my children. That is going to create an increase of anxiety, a feeling of hopelessness, depression. So I think the larger geopolitical context and also the economy is definitely impacting people's mental health and well-being. So more than ever, we're seeing the impact of those things, which drives up the need for additional behavioral health services for our community. And then also working on those social determinants of health as well, because those two things have to go hand in hand, right?
Yeah, and I think it also, we've had some pretty unprecedented times in those last 5 years, right?
Yeah.
Starting with COVID, we've seen the war in the Ukraine. We've seen the evacuation of Afghanis who have come to our community. We've seen May 14th and the tragic events of the winter storm that happened over Christmas 2 years ago. So these things are also compounding and becoming part of the factors that are really creating a challenge for individuals who are trying to overcome all of these very traumatic experiences, right? So that also is adding into the challenges we're seeing when we're talking about the needs in the mental health service community.
Which is great that you bring up all of the different things that have happened over these years and, even social determinants of health, because there can sometimes be a stigma around what types of, quote unquote, types of people have mental health issues or substance abuse issues. But just the stressors of the world that's compounding, it's made a lot of us much more vulnerable to anxiety, depression. And if you have pre-existing conditions, those can only compound. So it's really great that you expounded on that.
Yeah, it only takes one crisis, right? It only takes one thing. Somebody loses a job, right? Somebody goes through a divorce. It can only take one crisis for somebody to then have a serious mental health crisis.
Yeah, absolutely. So in talking about this support that you're getting from the state, was this a grant you had to apply for? Was it something that you were selected for and given? Can you take me through the process of how you received this assistance?
Yeah, so as an organization, we're regularly looking at the work we're doing. We're being strategic and thinking about how we want to grow and connect. And we sat down, and Katie and I and the team and looked at, what do we really want to do for our community? How do we want to grow our services? And one of the things we identified is we want to be able to support individuals with higher need mental health challenges, right? Those people who are at a critical point in needing additional support. So when the opportunity was posted in an RFP, or request for proposal from the department, from the Office of Mental Health, we looked at that and said, that is definitely the area of work that we want to continue to drive what we're doing. And we have so many complementary pieces that would allow us to be effective in providing the critical time intervention services. So that's why we decided to put a proposal into New York State when they called for proposals. We were so excited to be notified that we got the award. I think we were both away at a conference. We were standing next to each other on treadmills, and I'm reading my email, and Katie's reading their email, and Katie's like, "Oh my God, we got the grant." We were just like so excited at that moment. I think the rest of the day of the conference was kind of gone because we were on this high.
Yeah, and it came at such a critical time for us last year with so many funding changes that we were going through. It was just like, we need this, we need a win, right? I think everybody's kind of feeling that way, right? We need a win. So a major win for our organization and for our community. I think that is what is so important, right? This isn't just for JFS, right? This is for our community to be able to offer this service to our community.
Certainly. And I did want to talk about that too, the sorts of challenges you have been facing with the changing in federal funding, those sorts of things. What does it really mean to be embarking on a new endeavor in a time like this right now?
There's a lot of uncertainty, right? We know that. And so we could focus on the uncertainty, or we can focus on the excitement. And I think we're really trying at JFS to say we could get down and we could get hopeless and, the uncertainty, or we can embrace the potential, right? And I think with the CTI project and some of the other endeavors that we're taking on with a lot of the pivoting that we've been doing, our focus is really, let's embrace the excitement. Let's be creative. Let's look for opportunities, look for potentials and ways that we can serve the community. Maybe it's not going to look the same as it was before, and it might not look the same in the future, right? And I think that's really the approach that we have to take, and is to look at what can we do differently.
And we're using the term pivot, but to me, it's really living our values as an organization. We have 3 core values: to be a mensch, to be purpose-built, and to be resolute. And I really think by looking at what we're doing, planning ahead, being strategic in how we approach our work, we are being purpose-built by seeing the needs out there and bringing solutions we feel can help relieve challenges and can benefit our community. So I think it's really about living our values, as well as, looking at the moment and seeing how we can adjust to meet the needs.
And JFS, sorry to interrupt you, but
Go ahead.
JFS is one of the oldest nonprofits in Western New York. So I think the way that we're also looking at it, if JFS has been around this long, we want to be around for another 100 years. So how do we do that? And I think that's the embracing of the potential and the opportunity is to continue to be here for another 100 years to support our community.
Yeah, so it's by no means doing a new thing. It's building upon what you've been doing all along.
Yeah. Exactly.
So talking about some of the folks whom you exist and help to service, what types of populations do you think are most at risk of falling through the cracks, especially after psychiatric discharge here in Erie County?
Yeah, I think our seriously mentally ill folks. So I think, our folks that are living with schizophrenia, bipolar disorder, folks that are in that category with serious mental illness are folks that are typically just difficult to engage by the nature of the diagnosis, right? Especially people living with schizophrenia. A key marker of schizophrenia is poor insight into the fact that we have schizophrenia sometimes. So that can be really difficult. Then compound that with being homeless, not having an address, not having a phone. Those are all things that make it very difficult for us to engage with individuals when they have that serious mental illness, and then they're in the wind often, when they leave the hospital. So I think that those folks are very vulnerable. Then pile on top of that maybe a cultural element, maybe pile on top of that a linguistic barrier. So those are folks who are very difficult to engage, and historically we've struggled, as a state and as a community.
And do you think, even looking at someone who self-harms, for example, if they don't express suicidal intent, do you think it's more likely for them to fall through the cracks?
I don't know if folks that are intentionally self-harming fall through the cracks necessarily, because if it's not self-injurious behavior, I don't know that they're falling through the cracks in the same way.
Okay.
Yeah.
Okay, I was just wondering, if there was not a quite literal ranking, but as far as medical providers whom they deem to be more in need of emergency care than others, there's a lot of misconceptions that exist there. I think even with just the general public,
Yes, yeah.
So, in speaking of, folks with different lived experiences, different needs, I understand you're taking a personal approach, a peer approach to helping to provide the best services and care for these individuals. Can you tell me about this model and how it's been built off of your existing model?
Yeah. So one of the things that's unique about the CTI model is it is a team, an interdisciplinary team. So there are case managers, there are peers, there's a nurse. So being able to use our peers, our folks with direct lived experience with serious mental illness or substance use disorder, who can engage with clients in a different way than maybe a traditional mental health counselor or licensed clinical supervisor, licensed clinical social worker, in that they're able to share the direct lived experience that they have, right? And we know that there's often a lot of mistrust in, the health community, in the healthcare system. So being able to use that direct lived experience to engage with these clients is something that we're very excited about. And they can engage with them just in a different way and share the things that they've done to overcome these barriers that they've had.
Yeah, and we've used similar models in some of our other programming that we've provided, both in behavioral health and other areas of our work. For example, we have a program called Trauma Systems Therapy for Refugee Youth, where we're working with traumatized refugee youth to help them behaviorally regulate, and sometimes come all the way up to the point where they're receiving counseling services. And part of what makes that program successful is similar to the peer model, is that part of our core team, we have what we call cultural brokers, people from within a culture who have a connection to the language and the culture and the traditions, who can help people who may not traditionally receive clinical services have that connection to the support they need, through a means that, really connects back to the core of who an individual is, right? So we see that model working in some of our other programs, and we're very happy to be having that model also work through our critical time intervention project.
And it's an effective model. You hear a lot of times people will say, I don't want to go for help here because there are no people who look like me,
right,
or there are no people who come from where I come from in life or who deal with the issues that I'm dealing with. So it's great to have that that peer approach, it's a really, really effective method.
Yeah, people feel more comfortable, right? They feel more comfortable. They feel like this is somebody who looks like me, has experienced what I have. Oh, this person went through this and they're saying that this place is okay. You know, they're saying that there's people who they trust, that maybe they've even received services from one of these agencies before and they had a positive experience. So those are things that peers can do to really bridge. They serve as a bridge, really.
Yeah, and showing, this is the life that you can have. The stigmas and everything that comes along doesn't define who you are.
Exactly.
So going back to some of the populations that you're looking to serve, especially, through CTI, the severely mentally ill and those who deal with substance abuse, while the two are, by no means interconnected at all times, how often do you find that you have patients who are suffering with both?
Oh, there's a lot of co-occurring disorders. Yeah, lots of co-occurring disorders. And I think there's a lot of reasons for that, right? It's not uncommon that folks might be using substances to medicate some of the experiences that they're having. Maybe if they're somebody who's hearing voices, maybe they're using alcohol or cocaine to help them cope with those things. So there's a lot of co-occurring mental illness along with substance use disorder that we see.
And how does substance use in particular complicate discharge and planning and long-term stabilization?
It can be really difficult, right? It can be really difficult, especially if we have folks who are not willing to stop using substances. There might be people who are just not ready for that. And I think that that's really where that peer support can come in, because sometimes there might be an expectation that people need to maybe stop using their substances in order to enter into mental health treatment, where we know that that's not really true. We've really come a long way from the abstinence model. For a long time, it was, before you can get mental health treatment, you have to stop using. And so I think there are many folks out there who think I have to do both of these things at once. And that's really overwhelming to think about. Like, I have these mental health issues and I'm going to be asked to stop drinking alcohol. I'm going to be asked to stop using heroin or cocaine or any of these substances that may actually be the things that have extended their lifespan. Because if they were not using substances, they may have completed suicide, right? Because it's something that has allowed them to stay alive. So I think having that peer component, they can help dispel some of those myths and help provide education that a lot of our mental health and substance use providers are now using a harm reduction approach, especially here in Western New York, that the expectation is that abstinence is not necessarily the goal for everyone, and that might look different. So I think those are some of the things that peers can really help bridge those gaps with the folks that we want to engage with in this program.
While abstinence, or, to use layman's terms, getting clean is, I guess, a goal, is the preference, to have someone free from substance abuse or addiction. Mm-hmm. By, looking at older models that may be employed where you would have to stop everything all at once in order to get treatment, how harmful is that? And could it actually set someone up to be in a worse position than they were in the first place?
Yeah, absolutely. I think recovery looks different for everyone. And I think that is something that is at the core of the CTI model, is a person-centered approach. And really the way that we approach all of our services at JFS, right? We try to use a person-centered and trauma-informed approach, which means that recovery looks different to everybody. And it is not Dr. Diebold's job or any of our clinicians' job to make that decision for any of our clients, right? It is our clients' job to make the decision of what their recovery looks like. And I think that, some of our traditional models, we've learned a lot. We've learned a lot over the years in mental health and substance use. And we've learned that, you have to stop doing this, like this very power over approach. That is what has pushed a lot of people away, right? That is where some of the harm has been done. That's where some of the distrust of the healthcare system has happened, right? Is you have to do this in order to get help. Mm-hmm. What message does that send to people, right? If you don't do what we say, then you don't get help.
Yeah, it almost makes people feel judged.
100%.
Exactly.
Yeah.
And it goes back to our values and being purpose-built. We are here for the people we're serving. And if, what they want to do is take care of challenge A and not start working on challenge B, then we're there for challenge A with them. And that's regardless of whichever program they come into at JFS. It's really about building around the individual, about what their goals are, what they want to set as their priorities, and helping them achieve that.
It's absolutely always the most effective effective method you can take in any situation, an individualized approach, meeting the person where they are. But do you ever find that to be overwhelming in terms of the staff or resources that you have to support that individualized approach, given how many people you're actually serving?
Absolutely. Last year we impacted 27,000 lives in Western New York. That in itself it's a huge number of individuals. Whether we're doing direct service or supporting a family as a whole, it is time consuming to sit down, to hear, to listen, to plan with individuals, to follow up and help them stay on the track that they are helping to define. And the resources are becoming more and more challenging. We're seeing different changes in the federal funding structure, in the state funding structure. A lot of nonprofits like JFS are having the same kinds of challenges. So tapping those resources to be able to make sure the resources are available for the clients is becoming more and more of a struggle every day. We are looking at how can we do more with less, but at some point there's only so much you can do. And we don't want to get to the point where we have to say to somebody, I'm sorry, we can't help you because we don't have the resources available. So that's my job. I'm constantly looking at how do we make sure those resources are there? How do we make sure we have the funding coming in so that we can have the staff who can connect with the individuals, make sure that we have the dollars to pay for some upfront housing cost or food for individuals who are food insecure. And every day, that's something we're working on.
And that takes a lot of work and a lot of support and manpower. So this is a good place to pause on. When we come back, we will continue this very important discussion on what's next from BTPM NPR. Stay with us. We'll be right back.
Public media starts here, in our neighborhoods, our schools, our city halls, where decisions meet real life. BTPM NPR's local reporters are asking the questions that matter, listening to the people affected, and explaining what it all means for our region.
There's a lot of poor record keeping. There are records that lists that don't reconcile with other lists. There's a lot of gasoline that's being used that isn't properly accounted for. And there are a lot of people with take-home vehicles.
That's Erie County Comptroller Kevin Hardwick. He's outlining just a few of the issues his office found when conducting an audit of the county's vehicle fleet.
From paper trails to public impact, this is journalism that stays with the story and with the community it serves. Buffalo Toronto Public Media, NPR, produces journalism with depth, care, and purpose. This is public media.
The world can be so unpredictable, even unsettling. During these times, preserving the things that matter in your life becomes even more important. If Buffalo Toronto Public Media is one of the things that makes your life richer and provides you with information that helps you get through the day, then it matters to you. Strengthen it with your generous support before June 30th. Donate now by calling 1-877-456-8870 or going online to btpm.org. Take a stand and make it count.
From the fringes of the mainstream to the local music you love. Listen to Buffalo Toronto Public Media at the Bridge Monday through Thursday, 8 p.m. to midnight on BTPM NPR at 88.7 or from your smart speaker.
You're listening to What's Next, our place to discuss the important issues of our communities of Western New York and Southern Ontario. We want to hear from you. Click on the Talk to Us option in the BTPM Listen app, and we will work to get your questions or comments on the air. Do you have a story or concern that we should be addressing? Email us using what'snext@btpm.org. Together, we'll have the conversations that are needed. This is Buffalo Toronto Public Media, NPR.
Welcome back to What's Next from Buffalo Toronto Public Media NPR. I'm your host, Ijaz Jasil, joined again by Doctors Molly Carr and Katie Diebold. We're discussing a new critical time intervention team. And so I wanted to get into the discharge a little bit. How often are people being discharged from psychiatric inpatient care, CPEP, or the ER without stable housing already in place? Because as we talked about, social determinants of health are huge, and these individuals are at a higher risk for homelessness.
Yeah. I mean, I'm sure it's happening every day. Anecdotally, I don't have, stats in front of me, but I'm sure it's happening every day because we're in such a huge housing crisis and because resources are so limited. I think ECMC works very hard to coordinate with local agencies to help discharge people with the proper supports. But how could they possibly keep up with the demand and what is going on in our community? So best efforts to always try to make sure that folks are getting out of CPAP into a bed. But just the overwhelming demand that we're seeing in our community, it's very difficult to achieve that.
So when someone's leaving ECMC and they don't have a place to go, where's the CTI team come in? Like, what do you do at that moment?
Yeah, so what we would be able to do is we would be able to arrange for transportation to them to our local DSS. So we can get them an Uber. We can assist them with getting a bus pass. We can maybe even take them there if they're stable and able to be transported, take them to DSS and work with them to get them into a shelter for the evening. Or depending on what is going on with an individual, sometimes DSS may also pay for a hotel room. So somebody who is in a true homeless crisis situation, that would be something that we would be able to assist with getting them into a bed for the night. And then, of course, enrolling them in our services to be able to get them into a stable housing situation, right? Because a shelter is temporary, right? So we want to be able to get somebody into a stable, secure, safe living environment. And that's where CTI would collaborate with some of our other housing programs that we have at JFS or in the community to work to stabilize that individual in a secure, safe housing situation.
Definitely necessary so that it almost helps to prevent the cycle of re-entry into, the ER, into CPEP, these different types of those programs.
Right.
Yeah. So the need for this partnership, it almost identifies a few gaps that we have here in Western New York. Do you think there are enough outpatient behavioral health providers in the Buffalo area to receive people after they leave the hospital, or is the system still bottlenecked?
I definitely think the system is still bottlenecked. I mean, we're seeing it all the time. We're seeing it all the time and there's a lot of things that contribute to it. It's not just the system being bottlenecked. It's also insurance. Having enough providers that accept people's insurance, people not having insurance, people not knowing where to go. So there's a lot of issues that really are impacting that bottleneck. But I think we're seeing more and more that there's just such a huge need for folks to get in. And there's waiting lists, in a lot of areas in our community. And then especially for more specialized care, right? So I think that is something that really presents as a difficulty in our community is that not every mental health provider is for everyone, right? Mm-hmm. So if somebody has an extensive complex trauma history, right, that person really needs specialized care, such as like EMDR or internal family systems, something that is going to treat that trauma. So I think what ends up happening for a lot of folks when they're getting discharged is they might be directed to one provider who actually doesn't provide that specialized level of care for that individual, which can create a lot of frustration and can also, people can just be like, well, I give up. I'm coming to you, I need help, and you're telling me that you can't help me, right? Because I have this specialized need. So we have a very disorganized service system in Western New York. And I think that that's one of the big issues is people need that unique care based on what they're dealing with. Can't be like a one size fits all approach for folks.
Mm-hmm. Yeah. What do you think it's going to take to fix that problem? Is it collaboration between more local organizations, more state or federal support?
Yeah, I think a lot of what we see across the social service spectrum in general is that funding and programming can be very disjointed, right? Yeah. We as service providers, we're pulling in resources from everywhere we can. And, we get 3 different funding streams. One's federal, one's state, one's local, right? And they're all going to have they're going to all be disconnected. And we're going to try to marry them together to be able to provide a suite of services. But we're still reporting to the feds, the state, and the local government on different outcomes, different priorities set by them, not by us, right? Mm-hmm. So that's just like a small example of why we see kind of this disjointed, disconnected approach to being able to provide services, right? There is a need for some continuity in approach, right? Mm-hmm. And there is a need that continuity of approach come from starting with an understanding of the challenge and an understanding of what the individual may need, instead of trying to impose on those individuals what we think is appropriate for them, right? But yeah, it's definitely, it's a much bigger challenge than just in the mental health community. It's across all spectrums of social service. We see this kind of pull and tug on being able to do continuity of care when we have so many different funders and so many different guidelines that we have to operate under.
And I imagine that makes it even more complicated for the people who are actually seeking help to sort of navigate this very disjointed system. And then also just looking at the services that are available, someone not knowing where to go. What is the difference between calling 988, which is the suicide and crisis hotline, going to CPEP, going to the ER, and calling Jewish Family Services?
Yeah, 988, really the goal of something like 988 or like our local crisis services, for example, the goal of that is to provide the person support so that they don't have to go to the hospital. So that is, I'm feeling suicidal, I'm having feelings of self-harm, I'm going to reach out for help to 988 or our local crisis services, and I'm going to talk to somebody who's going to give me the things that I need to be able to not go to the hospital, right? So that's really the goal of those services, is to help wrap those services around people when they're in that critical time. Going to CPEP is when somebody is in critical need of mental health support, right? So somebody who has not just suicidal ideations, but suicidal intentions, right? So they really need that critical intervention, and they need to be seen by a psychiatrist. They need to be evaluated. So CPEP is really, that's the place to go if somebody is at danger to themselves or others, or they're having like an extreme mental health crisis. They're manic, those types of things. That's where CPEP comes in. So 988 Crisis Services is really there to be like, how can we help you not have to go to the hospital? What do you need? Are you already connected to a counselor? Could we help you call that person so maybe you can be seen tomorrow? So that's really a preventative measure to prevent folks from having to go to the hospital.
And then when people are not in an acute situation where they're not having an immediate crisis, that is when they would call us directly. They would call us at Jewish Family Services, whether it's to connect into our CTI program or into counseling services and our general clinical service or behavioral health program, where we can introduce them into the work that we're doing and not be immediately dealing with an emergent crisis.
Okay, thank you for that clarification. So when someone enters a program like this, what does success look like, for example, 6 months after discharge?
Yeah, I think that can look different for everybody. Again, kind of going back to this idea that recovery looks different for everyone. So I think it really depends on what is that individual's goal when they're entering the program. So if it's somebody who maybe their goal is, not only do I not want to keep going back to the hospital, because nobody wants to keep going back to the hospital, right?
Yeah. So,
that's probably a goal might be, I don't want to keep going back to the hospital, but maybe a goal is, I also would like to return to the workforce. So maybe a goal is, okay, that's your long-term goal, is to be able to return to the workforce within 6 months. What are the things that we need to help you do so you can get to that goal? Is it helping you get an apartment? Is it helping you get into mental health services so that you can learn some emotional regulation skills so that you are able to be back on the job, so that you're able to cope with the stress of being back on the job? Maybe that you're on medication that's going to allow you to be back on the job. So I think we really tailor that around what is that person's long-term goal, because success is going to look different for everybody.
Yeah, it's once again going back to that individualized approach and understanding everyone has a different story and a different journey in recovery. Does someone need a diagnosis, insurance, or referral to access JFS behavioral health services? Like what needs to be obtained, or I guess needs to be had before someone can seek help?
Yeah, I think for our CTI program specifically, those referrals are going to come directly from ECMC. So if there's somebody who's hearing, I know somebody who, could really benefit from this CTI program. Right now, we're accepting referrals only from ECMC just because of the nature of the program. But if somebody's listening to this and thinking, wow, like there's some things that are really resonating with me, that is, you don't have to have a pre-existing mental health diagnosis. you can call us. You can reach out to us. You can go to our website. If you think anything that we're saying resonates with you and you want to know more about our services, you can call us and we can connect you with one of our intake counselors who can collect your information and then get you linked to any of our services that we have, whether it's our behavioral health services, our care coordination, our housing. If there's something that resonates, you don't have to have an existing diagnosis to call us and to find out information about what might be available to you.
And care with JFS, particularly when talking about behavioral health, it's not, one linear process. Somebody may come to us, they're caregivers and they're taking care of their elderly parents, and it's a really stressful experience. And they may come and they may have 3 or 4 sessions with a counselor, and that might be what they need to be able to move forward and not be dealing with that same level of stress, anxiety, or depression that's coming from their experiences. So everybody's journey, again, is very unique. So don't think you have to come to JFS for a critical mental health crisis. You could be dealing with anxiety, depression, just struggling with the day-to-day of what's happening from the news to daily life, or a challenge that's happening in your life, like, again, caretaker of an older family member, or you've lost a job. We're here for all of those needs, for supporting individuals through all of those different places in their life.
Okay, good to know. In looking at the CTI program specifically, how many people do you expect the team to serve in its first year? Do you sort of have those benchmarks or goals yet? And how many staff members are going to be assigned to the team?
Yeah, there'll be 7 staff members total when we're fully staffed, and we will have capacity to work with 80 individuals per month.
Wow.
So yeah, we're very excited. So and we also cover 5 counties of Western New York. So we'll be serving Erie, Niagara, Wyoming, Orleans, and I always forget one. That's why I need my cheat sheet. Wyoming County. So we'll be serving all of those counties.
Okay, wonderful. So it's expansive. It goes beyond just the immediate Buffalo area.
Yes.
And those referrals, just to confirm and reiterate, are coming only from ECMC at the moment right now. Do you plan to expand that in the future if you get the support you need, take referrals from other organizations? Or
yes, they do have to come specifically from a hospital just because those are the regulations that are established by the Office of Mental Health. But we are hoping to work with some of the other hospitals that are in these counties. ECMC is very much the hub here in Western New York. So that's the rationale and our existing relationship with them for starting with them. But we do hope that this is a 5-year program, right? So we're only in year 1. We do hope as we're moving throughout this program, we're building the team up, that we will be able to collaborate with other hospitals as well.
Wonderful. And so it's going to be a 7-person team. How do you want that to grow or, sort of expand through the years?
Well, we've been told by the Office of Mental Health that there is a plan. Right now, this is a grant-funded program with dollars from OMH, but we have been told that OMH's plan is for this to be a Medicaid billable program. So what that would look like is for folks that are enrolled in the program that have Medicaid, we would actually be able to bill Medicaid for those services. So that would be able to expand, how many folks that we would be able to serve, and potentially also allow us to hire on additional staff members. So some of that we don't know, what that's going to look like, but we are hopeful that if this does go the way that OMH is hoping it will, that would allow for additional expansion. And they may also, OMH, if you're listening, give us more money. I don't know. Maybe there'll be more RFPs. I mean, this is a new program in Western New York, so if we demonstrate it well that it's needed, OMH might say that we need to have additional teams offering these services.
Well, I think that's certainly a fair ask from OMH, so I hope they are listening. And when we come back, we hope that you too, our listeners, will continue listening to this important conversation. There's more to come after this break on What's Next from BTPM NPR.
What is BTPM Plus? It's an evolution of Buffalo Toronto Public Media that brings you the best of PBS, where you can watch your favorite programs live and dig into collections curated just for you. And here's the best part. When you stream BTPM Plus, you're not just watching, you're supporting your local public media station, the journalism, the arts, and the storytelling that keeps our community connected. Visit btpm.org/plus today. Stream smarter, stream local.
Buffalo Toronto Public Media at the Bridge. Made by music lovers and powered by listener support. Locally owned and operated. Always independent. This is Public Media.
You're listening to What's Next, our place to discuss the important issues of our communities of Western New York and Southern Ontario. We want to hear from you. Click on the Talk to Us option in the BTPM Listen app, and we will work to get your questions or comments on the air. Do you have a story or concern that we should be addressing? Email us using what'snext@btpm.org. Together, we'll have the conversations that are needed. This is Buffalo Toronto Public Media, NPR.
Welcome back to What's Next, and thank you for staying with us during this heavy but important conversation on mental health, substance abuse, and how to get the help you need from especially a new program from Jewish Family Services. So while we are, talking about Mental Health Awareness Month, as was mentioned earlier, we are still in the midst of, what do you wish more people understood about serious mental illness in particular?
It's very normal. I think that is the biggest thing, right? I think that it is just as common as diabetes, congestive heart failure. I think that we still have a lot of stigma about serious mental illness, and it impacts many of us. It's very normal, it's very common, and it's extremely treatable. And people who live with mental illness, especially serious mental illness, can be just among us anywhere. I think that oftentimes when we're thinking about schizophrenia, we're thinking about the person talking to themselves homeless on the street, which certainly that can be true, right? We see that in our community. But it could also be me, could it be any of us, right? So I think that that's really important for us to understand, is that people living with serious mental illness can be productive. They can work. They're their parents, their mothers, their teachers. They're everywhere. And it's just as common as any other chronic condition that folks might be living with.
And as you mentioned, I think the stigma of what mental illness looks like is what keeps a lot of people from, talking about it, whether it's stigmas or cultural upbringings. Why is it important to talk about mental illness before someone reaches a crisis point?
I think just having the understanding that it can impact anybody is what is really important, right? Is that mental health screening should be as common as going to your primary care provider, going to the dentist. Those are all things that it impacts all of us. And it's not just serious mental illness. It's depression, anxiety, stress. Like, all of those things are things that any of us can experience, right? It's kind of like the nature of being a human, right? Is that we can experience this full range of emotions. And so I think screening for mental health is just as critical as getting those cavities filled, going and having your eye exam, right?
Yeah. And having those conversations, the more we talk about it, the more we normalize it, right? If we say, oh, that's a taboo conversation, or we don't want to tackle that challenging conversation, then we're continuing to stigmatize mental health. But really, it's a common thing, and we need to talk about it as if it's like any other health condition, right? We talk all the time about what are the signs of a heart attack, right? You see the ads. Well, let's also talk about what are the signs that says maybe it's time to go talk to a counselor, or talk to your doctor about what you can do to help you manage that depression and that anxiety that you may be feeling.
It's a great point. It's called mental health for a reason. It's as important as our physical health. So I'm really glad you made that comparison, because it's true. So I want to know, what at JFS are you all excited about as far as future programs or expansions?
We are doing a lot at JFS. I think part of the reason I love being the CEO of Jewish Family Services is that every day we are doing something new. We're doing something exciting. We're being strategic and pivoting to the needs of our community. We're continuing to grow our housing programs. We know that housing is a critical need here in Western New York. And in order to deal with mental health service, to provide effective mental health services, to provide effective care coordination in our wellness programs, we also have to be paying attention to things like housing, like critical support with benefits, with food insecurity. All of these pieces, they all come together. We are very proactively launching a new strategic plan at the organization. I'm not going to go into detail. We're still working through how we're going to be public about the strategic plan. But we think we're going to be able to have some serious positive impact in supporting families, youth, and older adults. So some of our new programming coming online will hit those target populations.
Very exciting. New JFS strategic plan coming. You heard it here first. So it's really a marriage then of partnering the services you already provide with this new incoming CTI program. Is there going to be a sort of overlap in terms of recommendations? If you see someone who, is about to be maybe discharged and they need somewhere to go, or they are unsure about how to access their food, are those services going to be immediately recommended within the JFS the circuit, or
within the spectrum of services that we provide? Absolutely. If we can keep that continuity of care within JFS, we will do that. But we're not afraid to also connect with partners and bring in partners to help in that whole care of the individual. So it's really about, is JFS the best person for this particular set of services an individual may need in connection with our CTI project or any of our projects? Or do we know this partner over here has a little more expertise with that will benefit this individual? Again, driven by the individual, driven by their needs, driven by their goals. So all of that goes into consideration on whether JFS provides those additional resources or if we connect with partners for those additional resources.
Yeah, and we may receive a referral through CTI for somebody who really needs CTI services, who may already be receiving mental health services from one of our other partners, right? So that's an opportunity for JFS as the CTI team. We want to help this other partner serve this client, right? So it's going to be a collaboration of working with those other service providers. The goal is not they come to CTI at JFS and then they can only get services at JFS, right? It's how can the CTI team support our other partners who maybe they're struggling to really serve this person appropriately. They might have a client who's not coming to their counseling appointments, but that client does like their counselor. They're just having barriers. So how can we help them? How can we help our other partners in the community through the CTI project?
And that goes back to this concept of care coordination. One of the things that JFS does, we have our health home programs for both adults as well as children, where we're helping people with critical needs manage the care that they need by coordinating with the partners who are out there to meet those needs. And so, it's kind of built into the work that we already do, is connecting people to those appropriate resources through our care coordination programs.
That's definitely become such a needed model, especially in the city of Buffalo, having more organizations that serve those multifunctional roles. So as this is What's Next, we want to, get to the solutions-based heart of what we do and the discussions we foster here. So if Buffalo is going to become a healthier community mentally and emotionally, what conversations or actions do you believe have to happen next?
I think the biggest thing is collaboration. I think we've all, especially in the last couple of years, I think all of us who work in human services have really realized that there's no need to be competing against one another. There's enough problems to go around, right? There's enough problems. There's enough people in need to go around that we can actually look around and say, okay, what am I really good at? What are they really good at? Like, we don't need to recreate the wheel. We can be working in collaboration with one another. And I think as a community, as a service community, we have made so many strides in the past few years to really say, hey, this organization's really good at this. Like, why are we going to start doing that if they're already doing that? What's the piece that can bridge us together, right? And relying on that collaboration, I think, is just going to be key, because as we talked about, it is disorganized. These are complex problems that we're dealing with. So it's not going to be just one organization that can solve them all. How can we collaborate? How can we combine our resources together to be able to tackle this together as a community? Not as one organization, but together as a community.
As a community, certainly. So for someone listening out there who may need help, but they're scared, or someone knows someone who needs help, but they don't know where to start, what's the first step?
Give us a call. We have our website to visit. You can see the programs that we provide, jfswny.org. or you can give us a call directly, 883-1914. Talk to somebody at our front desk. They're going to help connect you to the resource within the agency. And if we don't have that resource, somebody will help connect you to the resource outside of our agency. Don't be afraid to call. We are there for the community. We are there to help the community navigate some of the challenges that they're experiencing. So first thing to do, give us a call. We'll help you connect to the resources you need.
And if you don't have a phone, come to our office. I think that that's another big thing too, right? Like we have our office hours that are on our website. Come to our office, come in person. Somebody will greet you and talk with you and help you get connected.
Thank you so much for letting our community know about those resources. And thank you so much, Dr. Molly Carr and Dr. Katie Diebold, for joining me today for this discussion and for the work that you do. It is as taxing on mental health providers as it is for the individuals you service. So it's much appreciated.
Thank you.
Yeah, thank you so much for having us.
Thank you. And thank you so much to our listeners of What's Next. We hope you've enjoyed this conversation. And we hope that if you are someone who needs help, you will not be afraid or feel stigmatized to receive that help. Thanks so much. And join us again next time here on Buffalo Toronto Public Media and NPR.
Support for the BTPM NPR What's Next podcast comes from Health Foundation for Western and Central New York, partnering with the community to pursue racial and socioeconomic health equity. Learn more at hfwcny.org.